Hello, everyone, and welcome to this presentation called Under the Umbrella, which is basically diabetes in 10 minutes. And it's a privilege to be part of this Diabetes Chat World Diabetes Day event. So those that don't know myself, my name is James Ridgeway. I'm a person who lives with type 1 diabetes, and I'm also a diabetes educator for a team called Eden, which is based at the Leicester Diabetes Centre, and also a diabetes specialist nurse for the University Hospitals of Leicester NHS Trust. And what I'm going to do is basically touch upon the different types of diabetes. But first, I wanted to bring up this slide, which I think it's important to remember why we are all here. And November is a special month in the world of diabetes, as we know. Firstly, it's Diabetes Awareness Month, and November the 14th is known as World Diabetes Day. And World Diabetes Day was created in 1991 by the International Diabetes Federation and World Health Organization. And it's there to celebrate the birthday of Sir Frederick Banting, a Canadian surgeon who discovered insulin along with Charles Best, a research assistant, in 1922. But it's important to not forget the important role that John McLeod, a professor and endocrinologist at the University of Toronto in Canada, who allowed Banting to use his research facility and offered Best to support him in doing so. They first experimented on dogs, then cows, then James Collip, the fourth person, came along, a biochemist, and he made the insulin samples that they produced more safer for humans. They purified it. And then on the 11th of January 1922, so that's 37,197 days ago to be precise, Leonard Thompson, age 14, a young boy, was the first person with diabetes to receive insulin. And what a difference that moment has made to the lives of many millions around the world. So just a kickstart for you there. So diabetes, we're going to kick off now to understand the different types, but diabetes in general refers to a group of diseases that affects how the body uses blood sugar or blood glucose. I define it, the word diabetes, as an umbrella term that can positively connect a community, but yet there are at times it can cause misconceptions and negative presumptions. As you can see on the screen, there are many different types of diabetes, and this doesn't actually show all of them. My aim, though, is to look under the umbrella, under that general term, and inform you on what these particular 8 different types are, and how they are uniquely managed, and why one size really does not fit all. So first is type 1 diabetes, and this, as for many known, is an autoimmune condition. And this is where the body has attacked the insulin-producing cells, which we know are called beta cells. And as a result, natural produced insulin from the pancreas, which we call endogenous insulin, is no longer produced. And therefore, people living with type 1 diabetes need insulin to live, to survive. Insulin is crucial to allow the glucose to go into our cells to provide and be used as energy. It gives us the fuel we need. But sadly, there is no cure for type 1 diabetes yet, but the future does look very promising with advancing technologies such as hybrid closed-loop therapy and a treatment in particular called teplizumab, which is an immunotherapy treatment, also known as Tzield, which can help to delay the development of type 1 diabetes for some people on average by 3 years. And in relevance to the development of type 1 diabetes, most will, well, if not majority, will present with symptoms which we known to be like the 4 Ts, which are toilet, urinating more often, especially during the nighttime. First, feeling more thirsty, but it can't be eased, can't be quenched, tired, and thinner. So that's the first one, is type 1 diabetes. Then type 2 diabetes. So this occurs in the majority of people living with that umbrella term, diabetes. And this is where the pancreas is still producing insulin, but it's either not very effective or not quite enough. The causes, now they're multifactorial. Yes, people who are overweight and living with obesity does have an increased risk, but it's important to think of other risk factors as well. So physical inactivity, genetics, family history of type 2 diabetes, and then some more you can see on the middle row there. So we've got polycystic ovarian syndrome, gestational diabetes, certain ethnicities, and you'll find out another cause as well later. But there are many other causes for type 2 diabetes. We are also seeing an increased number of young people being diagnosed with type 2 diabetes. Parthakar did a really brilliant blog last week, I think it was, and he brought out a statistic which showed that 4% are now under 40 years of age of the total population of type 2 diabetes. And in comparison to type 1 diabetes, we're seeing more people diagnosed with type 2 between the age of 18 to 40 years. Treatment options are varied and they include diet, physical activity, oral therapies, particularly those with a cardiovascular benefit, non-insulin injectable therapies, and insulin. Again, non-size fits all, really. It's all dependent on what the person is needing at that particular point in time. There is no cure for type 2 diabetes, but you may have heard of the word remission. And this is where the person is able to achieve a HbA1c less than 6.5% under diagnostic threshold, or 42 millimoles per mole. And that's for more than 3 months without the assistance of any glucose-lowering medication. And the most effective strategies known so far are through very low-calorie diets and bariatric surgery as well. So another one I wanted to bring up was type 3C diabetes, a really important one to be aware of, I think, for many people. And this develops when another condition or health circumstance causes damage to the pancreas itself. It might be directly related to the pancreas. So this could be pancreatic cancer, pancreatitis, or pancreatic surgery. It can often be misdiagnosed for other types of diabetes. I tend to see people who've got type 3C that have actually been given a diagnosis of type 2 diabetes. For this type of diabetes, though, insulin treatment is usually the main strategy for this particular type. Gestational diabetes now. So this type of diabetes is one that develops during pregnancy, particularly as the pregnancy advances, usually diagnosed following a test called an oral glucose tolerance test. And usually they're normally provided between week 24 and 28, but some women are offered, who have certain risk factors, a test earlier on in that pregnancy. This type of diabetes usually goes away after birth, and therefore, all diabetes medication that was used during that time for women who develop gestational diabetes, it tends to be stopped after pregnancy. But the individual is known to be at a higher risk of developing type 2 diabetes, so annual diabetes screening is recommended for these particular individuals. So the next one is, I think, called monogenic diabetes, something which many might not be aware of. It's very rare and often misdiagnosed, and it's caused by a mutation, a change to a single gene, and genes provide instructions to make protein within the cell, and insulin is actually a type of protein. So monogenic diabetes reduces the ability to produce and use insulin. Generally, if a parent has this mutation of a single gene that affects diabetes or causes diabetes, their child has a 50% chance of actually inheriting it. So it's got a strong genetic family history to it. And genetic testing is the best and the only way really that is used to diagnose, along with history from the actual individual. Treatment can include lifestyle or glucose lowering medications and sometimes insulin. So we're going to have a look at some of the two particularly common types of monogenic diabetes, which obviously it's a rare type of diabetes, but common in its rare state. So the first is neonatal diabetes, also known as NDM. It mainly develops in the first 6 to 12 months of life, often mistaken for type 1 diabetes, but type 1 tends to be diagnosed after about 6 months of age. Some will either have a permanent state of NDM. Some, though, may have more of an intermittent one, a transient approach. So it comes and it goes, and it may go on for a while, and then it can reappear. And it tends to be that the individuals affected by this, the newborns that are affected by this, tend to be smaller at birth. But these individuals can still thrive and survive well post birth itself. The next one is MODY. So this stands for mature onset of diabetes of the young, as you can see on your screen. It's usually occurring in adolescence or early adulthood, so usually under the age of 25, and it can often be mistaken for type 1 and type 2 diabetes. Again, genetic testing is required for these individuals to actually give a diagnosis. The main feature with this as well is a typical family history of diabetes that's occurred over a number of generations, particularly, like, for example, grandparent, parents, and child. So when I see a patient who's been diagnosed with type 2 diabetes, I will always ask, what is your family tree like in relation to diabetes? And there's been times where it's led to genetic testing because of a query around whether it could actually be monogenic MODY for certain individuals. The next one then is LADA. Some of you may have heard of this. So this stands for latent autoimmune diabetes of adults, and it shares the features of type 1 and 2. Some people have called it type 1.5 or even slow onset of type 1 diabetes. And that's because, as I said, it's an autoimmune condition, but the destruction of the beta cells, those insulin producing cells, are at a much slower rate compared to type 1 diabetes. So insulin isn't always needed at the start of this type of diabetes, usually after about 6 months or so, sometimes a little bit sooner, which means that initially sometimes just oral glucose lowering medication is required, which was why it can be sometimes mistaken for type 2 diabetes. The key difference is that these individuals, like people with type 1 diabetes, will have positive antibodies. Then the next one is steroid-induced diabetes. So steroids are prescribed for different health reasons. Some of you may have had steroid medication prescribed before. You may have had it for an infection or chemotherapy or pain, and in different forms it can be given as well. And it's usually given for a short period of time. And taking steroids can cause high glucose levels and cause what we call a steroid-induced hyperglycemia. It's usually well treated with a sulfonylurea tablet called gliclazide, or some people may need to go onto certain type of insulin to help manage their glucose levels. When the steroid has stopped or the dose is reduced, then the glucose levels will calm and reduce as well. But for some people, in most cases, people can develop a steroid-induced diabetes. And the last one I wanted to touch upon was cystic fibrosis-related diabetes. This is known, can be termed as CFRD. And cystic fibrosis, as it says there, is a progressive genetic disease that can affect the lungs, pancreas, and other organs. And CFRD, cystic fibrosis-related diabetes, is the most common type of diabetes for people with CF. Around 20% of people with cystic fibrosis have CFRD. It It shares the features of both type 1 and type 2. Some people can have an insulin resistance, whereas some people can be deficient of insulin. And particularly this can occur at times where there's stress on the body. So illness, taking steroids, for example, during pregnancy, etc. Insulin treatment is generally recommended for this type of diabetes. So we're at the end of this now. So in conclusion, one size certainly does not fit all. Diabetes is an acceptable term to use as long as the user and the recipient with that word understands that there are many different types, and each type has, I think, an umbrella of its own, as underneath it, the umbrella itself, are many people living with that specific type, each with a different story to tell. And that brings us to the end. So thank you very much for listening.